Hello, everyone. I'm Nora Wong, Executive Director of the NORSE Institute. Welcome to the third annual NORSE FIRES Family Conference. The goal of today's conference and tomorrow's scientific symposium as well is to learn from the different ways we treat, study, and live with NORSE. We're expanding our focus today to include the field of rheumatology and the chronic phase of NORSE. Our breakout session is longer this year, so families will have more time to share their views. Families, thank you for being here. I know it's hard to look directly at the illness that has so changed our lives, and the basic science talks may frustrate you. Most of it is certainly over my head, but what I take away from these talks is the complexity of NORSE and the passionate drive of these researchers who are trying to find answers. Your questions and comments entered in the chat and made during the breakout sessions may not receive satisfying answers today, but they will inform investigators about what is important to you. Your concerns may be part of their research in the future. I know families want answers now as to why this illness happens and how to stop the seizures. You must also know that you play a role in how quickly research moves. The scientists need to collect enough data to draw meaningful conclusions and to attract drug companies to develop new treatments for NORSE. Each NORSE and FIRES person has their own unique story, and these stories deserve to be told to the people who will make good use of them. It is your loved one's data entered in the NORSE Family Registry, the long-term outcomes interviews, the NORSE FIRES biorepository, and other research studies that will help find answers in the future. Now I'd like to introduce Dr. Krista Eschbach, who is the lead for this family conference. Dr. Eschbach is Assistant Professor in the Department of Pediatrics Neurology and Associate Program Director of the Epilepsy Fellowship, Children's Hospital, Colorado. Krista?
Perfect. Good morning, everyone. And Nora, thank you for the introduction and for the time and energy you spend in planning the NORSE FIRES conference each year. I am going to start just very briefly, and then we'll get on to our speakers, but by acknowledging Nora and everything she has done for NORSE and FIRES research and patient care. She's the thread that has pulled us all together and connected us to help improve the lives of patients with NORSE. She's connected scientists, clinicians, patients, and families, and is really crucial to the research opportunities you'll hear about today. She's also connected with epilepsy organizations, including family organizations, the American Epilepsy Society, even the NIH, or National Institute of Health, to provide resources and support to not only patients and families, but also funding opportunities for researchers and clinicians. Lastly, Nora connects with patients and families individually, as many of you know. She facilitates this connection with quarterly Zoom calls and the breakout sessions that will occur today. So I would not be leading this conference today without the help and support of Nora. And so again, I wanted to start by just thanking her before we jump into everything. The other person I wanted to acknowledge before we take a brief minute to go over some housekeeping items is Dr. Maggie Gopal. Dr. Gopal holds a PhD in clinical psychology with specialization in neuropsychology. She's a postdoctorate in clinical psychopharmacology with training in EEG and neurodiagnostic training. She currently supervises all epilepsy clinical trials at Yale, NORSE being one of those studies. She also participates in Zoom calls with families and patients and has assisted in organizing the conference this year. So thank you, Maggie, for all your efforts, and to the Yale team. Some of you may receive messages from Maggie during the conference to confirm what breakout session you would like to be in at the end of the morning. For anyone who registered today or late in the day yesterday, please also send her a private chat message with each breakout group you would like to be in, because some of those, the late registrations, we weren't able to plan for those. If you have any technical trouble, please reach out to Maggie and she'll also help try to troubleshoot. A few other housekeeping items before we begin. So we will be monitoring the chat, but we encourage you to also use the Q&A. So if you guys see at the bottom of the screen, there's a Q&A option. So if you have any questions, please enter those in the Q&A and we'll answer those during our panel discussion or also type answers into the chat. During the discussion panel, there will be an opportunity to ask questions of our speakers. Feel free to raise your hand and then we can unmute you to ask your question, or again, use the Q&A function. We may not get to answer all the questions during the discussion panel, but if you type your questions in, then we can respond to that throughout the conference. The other thing is for people on here from different institutions, so clinicians and researchers, if you want to name yourself and your institution, that would be helpful as well. All right, now on to our agenda for the morning. We will begin with 3 talks from different clinical perspectives with experience in the care of patients with NORSE and FIRES. So we will start with Dr. Eyal Muscal. He is an associate professor at Baylor College of Medicine and the chief of pediatric rheumatology at Texas Children's Hospital. His research interests include neurologic manifestations of systemic autoimmune disorders. His interest in immunoneurology has led to a secondary appointment in the child neurology division as well. And he has a clinical and research interest in NORSE and is working to raise awareness of NORSE within the rheumatology community. So we're very excited to hear his perspective on NORSE and FIRES and share with us today.
Thank you so much. Let me get my slides up. So thank you everyone today. I give a lot of talks, but I'm always both humbled and honored when I get to speak in front of families who are truly our partners and our engine for any work we do with rare diseases, whether that's in rheumatology or neurology. And obviously I'd like to thank the NORSE Institute and the organizers of this conference for letting me speak. My other sort of name for this talk is breaking down silos of care, which I think rheumatologists are very good at. That is bringing different teams together. Those teams obviously include both physicians, but also families. I do have some disclosures. I have been on an advisory board for Sobi. That is the company that makes one of the medications I will discuss later, anakinra, though the advisory board was for a different medication for a rheumatic disease and not for FIRES or NORSE. I will be talking about medications that have not been approved for FIRES or NORSE. As a rheumatologist, unfortunately, almost everything I do ends up being off-label. So what do I hope all of you get out of my 20 minutes with you today, whether you're clinicians or family members, is to think about the potential role of pediatric rheumatologists in NORSE. Be aware, though, that different hospitals, institutions, and countries, that role might be taken care of by neurologists with expertise in neuroimmunology or by epileptologists that have that expertise, or at times even by immunologists. Hopefully we can talk a little bit about a topic called precision medicine, which is using targeted therapy or medications to dampen the immune or inflammatory system. And finally, I'll talk about a couple of those medications that rheumatologists use for a variety of disorders such as juvenile arthritis that appear to potentially have some effects in refractory status epilepticus. Now, I think of our time together as both families and physicians as walking along a beach. We are in the same real estate and we all have different skills. And many of you who have had loved ones in the hospitals can attest the fact that different physicians have different ways of articulating the same problem or different skill sets. Obviously, the intensivists will think of taking care of the ventilator, reducing the problems with infections, nutrition, and reducing organ dysfunction. Neurologists obviously are drivers of care. They're epileptologists, they're neuroimmunologists, they're often the leaders of ketogenic diet teams. And obviously rheumatologists are not the most important. I just bold us as potentially new players on the block. We take care of systemic inflammation. And really our wheelhouse is finding targeted ways to dampen the inflammatory response. And obviously your immunologists and geneticists will look for a cause for unexplained seizure syndromes. At times though we walk on the same beach, we don't walk in the same direction. And hopefully with family conferences and educational sessions for physicians, that will change. Now, this is not a subway map of Tokyo or New York City or Chicago. This is sort of how a rheumatologist thinks of the world. a fine map of different inflammatory pathways and different ways to turn off inflammation. As many of you know, when your children or loved ones have been sick, initially physicians think about such diseases as autoimmune encephalitis or lupus. And indeed, the physicians may try to get rid of B cells. Those are white blood cells that make antibodies that attack the body, whether in the brain or other areas. Rheumatologists may be asked to rule out disorders such as vasculitis, inflammation of blood vessels, or other conditions where immune cells directly damage the brain, some of those same cells being T cells. And we have medications for those, often taken for rheumatoid arthritis or sometimes chemotherapy. And finally, rheumatologists think of a concept called autoinflammation, or dampening what's called the innate immune system. That is the oldest part of the immune system that does not need memory. It's often a response to fragments of bacteria or viruses, or sometimes damage the immune system. And you can tell up here that there are a variety of inflammatory pathways or inflammation proteins or signaling proteins that are called cytokines. And you'll hear me talk about cytokines throughout this talk. So where does a rheumatologist come in? For years, I've sort of been asking this question, as others on this phone call have also. And indeed, is NORSE or FIRES a seizure disorder that activates the immune system and inflammation? Or is it an inflammatory condition that activates seizures? And you might say it probably doesn't matter as long as that inflammation, if it causes damage, can be stopped. Early in my career, and I am old enough that I can say that early in my career, and probably Dr. Risen, who knows me well, is probably chuckling at this moment, as neither of us are particularly old. Early in my career, during fellowship and early faculty, we weren't clear if there was a consistent pattern of immune dysfunction. And children or adults who had brain biopsies, we did not see classic immune changes as one might see in autoimmune encephalitis, in lupus, or in vasculitis. And it didn't seem as if we had apparent typical responses to medications that will affect B cells, the cells that make antibodies, or T cells, those cells that cause direct damage. But maybe we just weren't looking in the right place. There is a concept that potentially refractory status epilepticus is an autoinflammatory condition. And all that means is that the body's immune system is not attacking itself, but certain immune pathways are turned on by mistake. I would think of it as a light switch in your attic or in your bathroom that does not get turned off. So maybe we're making too much of certain inflammatory pathways, or perhaps we're not appropriately clearing them. And often that is after an infection or an injury. And for years, researchers, some of them potentially on our webinar today, have found that interleukin-1 beta, one specific inflammatory pathway protein, may be upregulated, meaning there's too much of it when there's injury in the central nervous system, whether that's a stroke or a traumatic brain injury or potentially seizures. And indeed, sort of the paradigm shift changes, or rheumatologists got more involved after 2016, when the group in the Mayo Clinic, utilizing multiple specialists, decided to use anakinra, which is mostly used, as I'll talk later, in such diseases as juvenile arthritis. They utilize in the child with FIRES. There's a couple of points here potentially that are also paradigm shifts or different ways rheumatologists view the world here. And that is, they start anakinra very early, within the first 7 days. They used it concurrently with a ketogenic diet. And in a second, I'll show you that maybe that synergy, that working together, makes some sense from an immune standpoint. Now, interleukin-1 beta is difficult to measure at the bedside, but there are some other inflammation proteins, so other cytokines that you can more easily measure. And indeed, this group in Mayo was able to show that some of those inflammatory pathway proteins were high in the spinal fluid before starting anakinra. They also noticed over here, I point to you the number of seizures per hour. They also noticed when they stopped the anakinra, and they had to do so because of concern of a serious allergic reaction, when they stopped the anakinra, the seizures came back. And indeed, they were able to keep the child on anakinra for 12 months with a better than expected outcome. And indeed, when anakinra was weaned, the seizure burden increased. So you might say, how might this work? And all I want you to get out of this diagram, since none of us in this call are immunologists, not even myself, there is a fine symphony of events inside an immune cell. So all this area I'm pointing to with my arrow is the inside of an immune cell. Perhaps some of those cells that work quickly without needing memory when there's damage or infiltration of bacteria or viruses. And this fine symphony leads to a cleavage of certain enzymes. Think of it as a high school chemistry class and doing a bunch of steps to get your final product at the end. And that final product here is making a lot of interleukin-1 beta, this inflammatory pathway. And indeed, this inflammatory pathway then leads to damage and propagation of the immune signal. Indeed, when we think of the ketogenic diet, it also seems to be able to reduce cytokines through the fatty acid changes. So perhaps it makes sense that they all work together. There is a cytokine story. So a group in Australia in 2019 showed that there are different inflammatory pathway patterns depending on a type of epilepsy you have, FIRES being the highest. In 2021, the Japanese team showed similar changes in this innate immune, the quick, not needing memory, inflammatory system. And some of these cytokines changed with therapy. Others did not, even when the child improved. And obviously, as we all know, multiple researchers on this call, so Dr. Hirsch and his colleagues both at Yale and throughout the world, showed that there were increased cytokines in adults with NORSE. This is not FIRES, in both their serum and the spinal fluid. These cytokines were higher when you had NORSE versus other forms of refractory status. And indeed, another paradigm shift here, that patients with elevation of these innate immune markers actually did worse at their discharge from the hospital and months later. And they implicated thus the role of the immune system, not just inside the brain, but in the periphery, looking at some of these cells I talked about before that were part of autoinflammation. They brought up the fact that perhaps early use of anti-inflammatory interventions was important. So anakinra is one of these medications. It's a rheumatology powerhouse. I think Dr. Calvert will talk about it more later, but it simulates sort of a natural product of the body that sits in the docking station of immune cells and blocks the immune signal of interleukin-1 beta. It's FDA approved for a variety of periodic fever syndromes, and we also use it in rare forms of juvenile arthritis. It's been approved transiently for the use of severe COVID inflammation, both adults and kids, and a variety of other immune conditions, including the adult type of systemic juvenile arthritis. And as Dr. Calvert will discuss, it's got very short half-life. If there's any side effects or issues, you can take it away without any untoward effects. We found in other rheumatic diseases that it is able to get into the brain at levels even much higher than the body's own production of this blocking system. And it appears in other rare rheumatic diseases that it seems to reduce those cytokines, those inflammatory pathways, even in the brain. And this can be followed with improvement of the patients. Now, Dr. Lai and myself and others at Texas Children's were able to kindly ask a variety of clinicians throughout the world in 13 countries to share data retrospectively, meaning this was data that was obtained clinically in 25 children. And indeed, it appeared to be safe, as it is another rheumatic condition. Only one child had to stop it for infection or low blood counts. And it appeared that the earlier you bring this medication on, as the Mayo group showed in 2016, the reduced time on a ventilator and the shorter time in the hospital. Though Dr. Eschbach and others, and I think Dr. Eisen will talk about this, there were still deficits at discharge and later on in children who were on anakinra. So back here again, what if a child or an adult does not improve on anakinra? Are there other inflammatory pathways that may affect seizures or inflammation in the brain? And indeed there are. I highlight one of these here, interleukin-6. And indeed, we do have a way to block this signaling system. Again, interleukin 6 or IL-6 is able to lead to signals within an immune cell, which will then propagate an inflammatory pathway or signal. And in the lab, researchers made an antibody against this specific inflammatory protein. This medication is called tocilizumab. It's usually given as an IV and can block this inflammation. It is FDA approved in the United States for various forms of arthritis, but it's also used off-label in vasculitis, autoimmune encephalitis, and COVID hyperinflammation. So indeed, for the last couple of minutes here, Dr. Wickstrom, who I know is on today, was able to bring multiple pediatric and adult neurologists, and also a few rheumatologists to his credit, to think about the use of various medications. And indeed, the first 72 hours, if there's any immune medications brought to the table, they're not about autoinflammation, but they're about targeting B and T cells. So potentially autoimmune encephalitis or other immune conditions. If a child or adult with FIRES or NORSE does not improve, then people think about targeting, again, B cells if you found an antibody and they're concerned about autoimmune encephalitis. But if there is no cause for what adult neurologists often call cryptogenic NORSE, you might target interleukin 1 with anakinra or interleukin 6 tocilizumab. Finally, I know there are a variety of questions from many of you who are dealing with NORSE after the acute phase. Could immune medications be brought to the table? And we don't have a lot of information, but I'll share with you what we have. And I'm pretty sure Dr. Calvert and Dr. Eisen will do the same. So a group out of Italy showed that in the acute phase, they did not use anakinra. Again, a ton of seizures per day. And the child seemed to have their seizures burden reduced. But then about a year and a half after, their seizures increased again. They brought anakinra to the table and they were able to get reduction of seizures for about 8 months. Another group sort of was able to collect information on 5 children, and this is the use of medications even 8 to 9 years after the acute event. They used anakinra initially. One child was switched to tocilizumab because anakinra did not seem to work, and they used the medication for about 9 months. In 3 of those patients, though seizures did not go away, there were reductions in the seizure frequency. The medication again seemed to be safe and reduced some of their rescue medication, and there was thoughts of maybe some improved cognitive status. As Dr. Calvert will talk about, I'll not spend much time on this. There are risks with immune suppression. That's often risk of infections. With tocilizumab more than anakinra, there could be some allergic or systemic reactions and some rare adverse events, including the GI system. As I said before, these medications are not approved in FIRES or NORSE. What the data we have is observational studies. That is researchers and clinicians throughout the world trying their best to share information. We are all hopeful that some of the researchers on this call are working towards prospective clinical trials. That means enrolling families right at the beginning with the ability to collect data as we hopefully treat children and adults in similar fashions. So thank you again for your time. Where do I see the future? Rheumatologists are bridge builders. We get paid to bring local teams together, and that really has to include families and not just providers, but also if it is providers of different specialties with different expertise, and we leave our ego at the door. I've had many families, whether with NORSE or lupus or autoimmune encephalitis, tell me that they had greater hope when they saw multiple physicians talking at the same time, or that they knew that they were talking behind closed doors. There needs to be shared decision-making. That means that physicians and researchers are very open and honest about what we know and what we don't know. And we ensure that families are able to make informed and honest decisions regarding situations that are immensely, immensely difficult. And as you know, that is probably one of the biggest understatements you'll hear today. Hopefully, teams can continue to share experiences in real time, whether that's through conferences, or WhatsApp groups, Zoom, or a variety of times throughout the year when people get together at academic meetings. And finally, as I said, I think we're ready that some of the work that researchers have done the last 5 to 10 years can move towards clinical trials. And I thank you all for your time and listening today. And I look forward to being on the question and answer later to answer other questions maybe I did not get to. Thank you again.
Thank you for that great start to the conference. We have some great questions already entered in and some that you addressed as people were typing them. You covered that, so thank you. Following, you will hear from Dr. Sarah Reisen, who is also at Baylor College of Medicine. She's an associate professor. Dr. Reisen is currently a faculty member in both the Department of Pediatric Neurology as well as the Myers Center for Developmental Pediatrics. After completing training in neurodevelopmental disabilities at the Kennedy Krieger Institute and Johns Hopkins School of Medicine in Baltimore, she then pursued a 2-year clinical and research fellowship focusing on children with traumatic brain injury. Dr. Reisen is a board certified in pediatrics as well as neurology with special certification in child neurology. She believes in a comprehensive and interdisciplinary approach to the evaluation and management of neurodevelopmental disabilities and have interests that include the full spectrum of pediatric traumatic brain injury, going from mild concussions to severe brain injuries, acquired brain injury, and neurocritical care. And we've asked her to speak at this conference to share some of her perspectives about recovery from NORSE and FIRES. Oh,
I am, let's see. Did it share my screen? No. Has it shared the screen?
Yep, that's
Okay,
perfect.
perfect. All right. Thank you for that lovely introduction. So I do think, as Dr. Muscal was talking about, rheumatology being maybe newer players in the field of NORSE and FIRES, neurodevelopmental disabilities is a pretty little known subspecialty within pediatric neurology. As part of the training, we do have additional time with learning more about cognitive disorders, learning disabilities, motor behavior disorders, and really the full spectrum of neurodevelopmental disabilities from all types of etiologies. So I think it's really exciting to become more involved in the chronic phase of NORSE and FIRES, and I think it's incredibly important. I'd like to thank the NORSE Institute for this conference, and I'm truly honored to be here today. I have no disclosures, but I do have a disclaimer. You're the expert, and I know that, and so I'm actually a little bit nervous because I'm really humbled and excited to learn from you as you're in various stages of this journey, and so I wanted to make sure to acknowledge that from the beginning. There are several challenges in the talk on recovery. So NORSE and FIRES are incredibly rare, completely unexpected conditions with very severe onset. I don't think anyone has ever had the exact same course. So while there is literature on outcomes from an overall small number of patients, it doesn't necessarily specifically predict the exact course of recovery for you or your loved one. Despite the unknowns, it's important to remember that the brain is an incredible organ, like consistently surprising and amazing us. So hope is always there. Based on the questions that many of you sent in, I want to go ahead and acknowledge that the cognitive and behavioral sequelae are some of the most impactful to quality of life and function and seen commonly in brain injury clinics, but somehow they're also the least reported in the literature. Rightfully so, NORSE and FIRES really as epileptic encephalopathies or seizures have been the primary and initial focus. As we're learning more about the pathophysiology and improved treatments and targeted immunotherapies, the other effects such as cognitive and behavioral impairments are also becoming to reach the spotlight. So I would truly encourage you to participate in the NORSE FIRES registry so we can truly better understand the course of recovery. I also got a little bit philosophical of what even is recovery, and I started really thinking about this because even for those who return to their functional baseline, everyone is inherently changed by the nature of NORSE and FIRES. So when thinking of recovery, I really think of habilitation and healing. The child, the adult, caregivers, everyone is moving forward on this journey. It's really important to celebrate victories and to be proud of how you're doing. It's equally important to acknowledge where you or your loved one may be struggling and to seek support and services. Everyone wants to optimize and function and maximize recovery. But there are so many different layers to function and recovery that in the end, this is really a long journey. With the power of families and a medical community working together and through ongoing research, we will learn how to best support each patient throughout recovery. I think that is kind of a theme that Dr. Muscal just emphasized, and that's really important today. In a broad sense, NORSE and FIRES can be considered an acquired brain injury. The severity of seizures, the extent of acute treatment, often requiring a medically induced coma and steroids and additional therapies, the risk of acute secondary injuries, periods of hypoxia or possible clotting, infections, the length of the hospitalization, the number of anti-seizure medications at discharge, all of these impact the brain diffusely. In fact, the most common MRI finding is diffuse brain atrophy. So when the brain is impacted more broadly, all areas of function are at risk. The challenge is we do not know which areas will be impacted specifically, to what extent, or how that will contribute or not to functional deficits. You notice at the bottom of the slide in green, there are some related complications to all acquired brain injuries. And some of these may seem familiar to you. So in a broad sense, NORSE and FIRES are acquired brain injuries. And this is helpful because then we can rely on evidence and clinical experience in treating patients with other more common etiologies of brain injury. So as you know, NORSE and FIRES used to go by many different names with inconsistent diagnostic criteria, a range of treatments, and these factors hindered a clear understanding of these conditions. But now that we have consensus-based clinical definitions, treatment algorithms, and guidelines that are more well-defined, we're noticing increased recognition, more consistent treatment, which also leads to improved survival, as well as a wider range in morbidity or ongoing symptoms. So with this clinically defined group being diagnosed, we need to better understand the outcomes to help us learn more about the evolution of process over time. So recovery is actually quite complicated to characterize, but this is a very simple schematic. So you have the acute injury, and then you have neural repair. So the brain is trying to repair and recover throughout the time. So that is a very simple schematic of brain injury. In more common conditions, such as pediatric traumatic brain injury, we have a lot of data and have a pretty good understanding of an overall trajectory of recovery. So if you notice, you have the initial acute brain injury with a pretty rapid improvement in symptoms. Now, the degree and extent of recovery from traumatic brain injury is variable, but this is an overall schematic. However, we also have learned that over time, the rate of improvement in gain in skills tends to slow down and then even plateau after a year or two. And so, understanding this trajectory when doing research and how does an acute change or an ongoing treatment affect outcomes, it's really important to know what you expect to begin with. There's also different skills. So within different skills, there are different patterns of recovery. So after, again, pediatric traumatic brain injury, because that's where the most evidence is, you'll see that both the neurological symptoms improve most rapidly, as well as the cognitive symptoms. However, the behavioral and social symptoms and deficits tend to increase over time. One commonality of all etiologies of brain injury is that global scales will show improvement. So big picture, you're making gains in skills. However, you also have an increase in the number of neurodevelopmental deficits over time. And then also you can have different trajectories of recovery even within the same one etiology. So some patients might be non-responders or some might be slower to respond, whereas others might make very rapid gain in skills that tend to improve a little more slowly over time, but continue to make those gains. However, there are differences between the long-term clinical course of NORSE, and other etiologies of acquired brain injury. So in NORSE, you have ongoing seizures, readmissions to the hospital for seizures or status epilepticus or procedures. Most patients are discharged home on 3 or more anti-seizure medications, which have notable side effects, including impairing cognition, alertness, mood and behavior disorders. So ultimately, it's important for us to understand the details specific to NORSE and FIRES course of recovery, rather than just as a global acquired brain injury. There's very little data to establish developmental trajectories or patterns of recovery following NORSE and FIRES. But Dr. Muscal already mentioned the study looking at the long-term neuropsychological outcomes in children with FIRES treated with anakinra. there are 5 children, only 5 children that had longitudinal neuropsychological data. And this graph is showing the IQ. In 3 of the 5 children, over time, their IQ declined, which is different than what you would expect from a traumatic brain injury where you expect ongoing improvement. And I don't want this to in any way be discouraging. It emphasizes that there are differences between NORSE and traumatic brain injury or other types of acquired brain injury. And it really stresses that we need to learn more about the course and trajectory of recovery specific to NORSE and FIRES. And there's so many other variables contributing to function and IQ, such as the medications, ongoing seizures. And then we would also want to know, do new therapies or chronic therapies, could that change this course? Additionally, when looking at the slide and the decline, note that, with ongoing longitudinal recovery, we don't know if there would be, kind of plateauing or even improvement in this IQ. So again, I don't want this to be discouraging, but it does emphasize the importance of learning about the course of recovery from all of you all. So from the clinical perspective, there are different aspects to recovery. Of course, there's the seizure control. And there's also memory and learning deficits, executive function problems, language and social skill deficits, gross and fine motor impairments, problems with sleep, fatigue, endurance, mood, and behavior. All of these symptoms can contribute to the functional impact of NORSE and FIRES. So the symptoms can impair your activities of daily living, such as your self-care, your ability to brush your teeth or dress yourself, as well as activities of daily function, driving, going to the grocery store, ability to coordinate shopping and organize. Whether you can attend school or not, and if you are attending school, are you able to learn at the appropriate rate? Similarly with work, are you able to attend work? And if so, are you able to complete the skills needed for a successful work day? Additionally, there can be a functional impact on family interactions and social interactions. And I emphasize social media judgment because I think back when I was younger, we didn't have social media. So it is a risk whenever you have some mood and behavior and executive function changes. In the medical world, recovery is measured through outcome scales. And I wanted to pull up an example of a very common adult neurology outcome scale for you to understand the literature. So this might seem like too much detail for this talk. Why would you need to know an outcome scale? But it matters because you might hear a provider saying, oh, good outcomes or poor outcomes. And that statement could be coming from a measure like this. And so I would love for you to read it. And if anyone wants to put in the chat, what are you observing? I don't see the chat on my screen. Oh, no, I've lost everything.
Okay. When you're back, remind me to give me our credit card.
This is funny. I've completely lost my screen. I might have to escape.
So we can see your slides again.
Oh, okay.
Yeah.
I don't know.
If you want me to look for things in the chat.
No, my whole Zoom went away. The Zoom itself. I found it. All right. I'm sorry about that. This is also, nope, it's gone again. Are you able to see my slides?
Yeah, it's not in presentation mode anymore.
There we go. Now can you see it? And then I'll have to just skip through. I'm sorry about that. That's annoying. Okay, so what do you all see? I think that since I can't see the chat, I'll just go ahead. I mean, it's really broad. And it's focused on motor skills in your activity of daily living. So if you think about what's missing, if you're having cognitive impairments, behavior disorders, difficulties with your social interaction, your language skills, this is completely missed. And so, the abstract might read, outcomes are poor or outcomes are good, but it is based simply on this kind of broad scale. And I think that's really important to understand. That not all outcomes are the same and not all outcome measures are the same. You really need to get into the details to understand what, an article is talking about. There are a lot of problems with outcomes data. When people are looking to see what's published, you can imagine in a rare condition like NORSE and FIRES, there's just little information, and it's based on a limited number of patients using these broad outcome measures. There has not yet been a natural history study for NORSE or FIRES. And that really gives a lot of enriched information on the course of recovery throughout the spectrum of the condition. Given the acute severity of seizures, it's not a surprise that the most information is on seizures and seizure outcome, and that's very appropriate. But beyond epilepsy, the outcomes reported are very broad, and many of the scales have a bias towards motor function, or they're inappropriately applied using an adult scale in a pediatric population, or not factoring in all the variables. Since there aren't consistent comprehensive measures evaluating areas that are affected, there's really little to guide us on what to truly expect. And these problems, again, emphasize the importance of learning from each of you, and the importance of this conference in particular. Earlier this year, a large review, a systematic review that looks at all of the studies that have reported outcomes in adult and children with NORSE was published. And this is great because it saves me from having to go through, well, there's this study with these outcomes and this study with these outcomes. I'll just kind of present this one study that summarizes all of the evidence so far. When we're looking at how adults do, the N is the number of patients included in all of the studies of NORSE and FIRES. And there are 212 patients in the reported literature that were included. We only have information on outcomes for seizures for 198, disability in 37, cognitive outcome in 22 patients, and only 7 patients have reported psychiatric outcomes in the adult literature. So there is very little information. For seizures, 5% of adults are seizure-free on no anti-epileptics, and 41% have ongoing medically refractory epilepsy. For disability, 30% have a complete recovery with ongoing symptoms, but fully independent in their ADLs. 57% still have problems and some difficulties with function, but remain independent in their activities of daily living. And then 20% have a severe disability and are dependent on other caregivers. Cognitive outcome, again, only including the 22 patients with reported data. 13% remain in an unresponsive wakefulness state, which is the new terminology and better terminology for a vegetative state. 14% have reported normal cognitive function, but 55% report ongoing memory impairment. And for psychiatric disorders, 3% have a new onset psychiatric disorder, including ADD, psychomotor agitation, and personality changes. There is more information on children, looking at 499 children. But again, the numbers quickly drop when you're looking at disability, cognitive outcomes, and psychiatric outcomes. So 10% of children are seizure-free on no anti-epileptics, whereas 58% have medically refractory epilepsy. 22% have a reported complete recovery, whereas 63% are independent, but 81% have this unfavorable outcome, which actually it kind of overlapped with the independent data, so it's a little bit confusing. So it's pretty unclear because this also includes children with only moderate disabilities who are still independent in their activities of daily living. From a cognitive perspective, 13% remained in an unresponsive wakefulness state. 14% had normal reported cognitive function, whereas 55% have ongoing memory impairment. And 11% had a new onset psychiatric disorder, including ADHD, aggression, lability, emotional lability is very common, apathy, and conduct disorders. So the very appropriate summary of this large review of all of the data of NORSE and FIRES in adults and children is that these findings reflect the lack of standardization for reporting of outcomes, particularly for reporting symptoms other than seizures, and may also reflect a gap in the care of these patients after initial hospital encounters. So going back to the neuropsychological outcome study in children with FIRES that were treated with anakinra, I think this table emphasizes another conundrum that we see really commonly in brain injury. If you look on the left, you see that all 6 patients are independent in ambulation and speech. So they are walking and talking. And this is awesome and very, very important. However, these big functional skills can also almost overshadow the nuances of recovery. So that's what's often called in the brain injury world an invisible injury. And it's hard to see because everyone is celebrating very appropriately the walking and talking and gaining of these great big skills, but there's still these deficits and impairments that really affect function and interactions with others. And understanding these nuances is what will really help us best support you and your loved one. So even at our own institute, we were looking at the neurocognitive patterns of children greater than 2 years after fires, and recognized quickly that a full-scale IQ isn't really sufficient to characterize these patients because they're isolated strengths and weaknesses that aren't accounted for by these broader outcome measures. The most common cognitive weaknesses were processing speed, working memory, fine motor speed and dexterity, attention, and executive function. Thinking of cognition and learning after NORSE, the deficits fit into broad categories such as inattention, memory, planning, as well as specific actions and ability to complete tasks, forgetting to do things, losing things, not going places. The cause is largely unknown because it's likely a combination of factors. There's the brain injury from the acute force, the contribution of ongoing seizures or potentially ongoing pathology, medication side effects, the cognitive dulling from some anti-epileptics or other medications, secondary to other sequelae, so sleep disorders, mood dysregulation, all of these can also impact your cognition and learning, as well as an adjustment disorder to everything, the kind of very significant clinical course, as well as ongoing functional deficits. So potential treatments can include cognitive rehabilitation therapy, which can be restorative, trying to train your brain back to reestablish those pathways, or compensatory, saying working around the areas that are more difficult. Executive function coaching can be helpful for those with higher functioning deficits. Thinking outside of the box, so dyslexia programs can focus on nonverbal ways of learning and communicating. Medication management is often or may be necessary, especially if safety is at risk or the deficits are impacting your ability to participate in activities or therapies. Medication treatment is symptom-based. And there's really a golden rule, especially in pediatrics, of starting low and going slow, because after a brain injury, trying to be too aggressive too quickly can lead to side effects that then make it intolerable. And it's and just there seems to be an increased risk for side effects from these medications. And then which providers, it really depends on the provider. So unfortunately, it does require you or your caregiver or loved one to be pretty proactive in requesting a referral if you're having concerns that aren't being addressed. Neurodevelopment, psychiatry, physical medicine, rehabilitation, neuropsychology, speech language pathologists can all help with evaluating and treating these conditions.
Sorry, Doctor, I just wanted to jump in to let you know from a time standpoint.
Oh, that's great. Because everything's gone on my screen, as you could see.
That's all right. Just a couple more, and then hopefully you'll be able to go
wrap this up. I actually only have, I think, a few more slides, like two more slides that are really important.
All
so
right.
I think just noting the behavior problem. So after traumatic brain injury, it's super common, and similarly after NORSE. I think a lot of the questions did revolve around mood and behavior disorders, again, fitting into broad categories. Similar to the cognitive and learning, the causes can be quite similar. And we can talk about that in the breakout group, but the treatments are the same, using environmental modification, psychology, behavior management, and medication management. So I really think for overall recovery, a multidisciplinary team is really critical, all working together and thinking of the long-term recovery. Obviously, there is a lot we need to learn, and we all need to learn it together. And I thank you.
Thank you for all of that great information. I think some of what we didn't have just quite as much time for at the end will hopefully come up during the panel discussion. I know we have a couple of questions about from a mood standpoint that we can cover. But I just wanted to also make sure that we give enough time to hear from Dr. Calvert as well. So she's going to be up next. So Dr. Calvert is a board certified pediatric clinical pharmacist who served as a clinical pharmacy specialist in child neurology for the past 8 years. She was the former neuropharmacologist at Children's Hospital Colorado and has participated in the acute and post-acute pharmacological management of patients presenting with NORSE and FIRES. Unfortunately for us here in Colorado, she has recently moved out of state and accepted a position outside of academic medicine, but we are excited to have her here for her talk today.
Thank you, Krista. Let me share my screen. Okay, are you able to see my slides okay?
Yes.
Yes.
Wonderful. Okay, let's put this down. Thank you so much for the opportunity to speak at this year's family conference. It truly is a privilege to be here among families and loved ones that are affected by NORSE and FIRES. And today I'll be discussing the pharmacotherapy in NORSE, what we know so far. I was asked to be a speaker at this conference when I was the neuropharmacist at Children's Hospital Colorado, as Dr. Eschbach mentioned, but my husband's job did relocate us and we're moving as we speak. So I'm unfortunately no longer at Children's, but I was recently hired by Marinus Pharmaceuticals. So I do have a disclosure. This presentation is my own and does not represent the content of Marinus Pharmaceuticals. By the end of this short talk today, we'll have reviewed the recent international consensus recommendations, focusing really on what we know about the pharmacologic management of NORSE, including FIRES. We'll be able to recognize what medications are more broadly used in the acute versus the post-acute and chronic phases. And we'll discuss the importance of early initiation and aggressive escalation of immunotherapy in cryptogenic NORSE, with which Dr. Muscal also highlighted. The audience is likely very aware of the consensus definitions, but for those who aren't, there was a multinational panel of experts who came together in 2017 and really established the standard definitions for NORSE and FIRES. So I'll just quickly review that NORSE is used to describe the clinical presentation and is not a specific diagnosis, and that FIRES is a subset of NORSE. Currently, there are no randomized controlled trials in the treatment of NORSE and FIRES, which has been highlighted throughout the last two talks. This is likely due not only to the really rare nature of this disease, but also the hyperacute and complicated clinical presentation. The current data that exists, as alluded from the two talks, are from case reports, case series, limited observational studies with no consensus guidelines. So many aspects of the clinical care in patients with NORSE really remain unaddressed. And the existing treatment approaches differ by provider and institution. And that was really highlighted when a survey that was published showed that between neurocritical care providers in the US, 2/3 of the institutions that they came from did not have a protocol to evaluate or treat patients with NORSE. As solid evidence and diagnosis of treatment is scarce, a Delphi consensus approach, so an international consensus group of 84 experts in the field, got together and used the Delphi method to come together with some recommendations and to really lay a foundation for the research consortium. So this supporting evidence they pulled together, and it also highlights current gaps in the literature that hopefully we can focus on. One of the big things that it highlighted are that these patients really should be managed at a tertiary center with multidisciplinary expertise, as highlighted by the first two talks. And when they talk about the pharmacologic management, they break it down between the acute phase and the post-acute or chronic phase. So really, when we're thinking about the management of you or your loved one, we're looking to figure out what is that underlying cause, all while controlling the status epilepticus, trying to avoid complications in the ICU. We're going to also be trying to treat the presumed immune-mediated process, support you and your loved one during that, and then work on the rehabilitation services once we're out of that acute epileptic phase. And that graph is just depicting some of those challenges. The goal of the acute phase is really to gain control over the refractory status epilepticus or the super refractory status epilepticus. The acute treatment of seizures with anti-seizure meds should be similar to the treatment of seizures and other conditions. And so initially, we're typically treating you or your loved one with benzodiazepines such as lorazepam, diazepam, or clonazepam. And then we're going to follow that up with standard anti-seizure medications, as in most cases of status epilepticus. There really is a preference that we give to medications that are available in intravenous or IV form, such as valproic acid, fosphenytoin, levetiracetam, phenobarbital, lacosamide, and then more recently, brevitiracetam. NORSE and FIRES, we know, don't respond to at least the first 2 lines of treatment traditionally. And so typically additional medications are required to gain control of status epilepticus. The 2 options that we either try are adding on more anti-seizure medications, or we may possibly have to induce you or your loved one in that pharmacological coma with the anesthetic medication. So I'll just briefly talk about the treatment of seizures in NORSE and FIRES with anesthetic drugs. We follow the same principles as the treatment of status epilepticus or refractory status epilepticus and for other etiologies during that initial 48 hours. The anesthetic agents that are most commonly used include infusions of midazolam or barbiturate, so the pentobarbital or phenobarbital, or we can use propofol or ketamine. We do see of the 3 that midazolam may have the best safety profile, but could also be associated with a higher risk of recurrence. None of these medications are without side effects, and so we don't take this lightly and know that there is a risk-benefit ratio here for you and your loved one. And then we move into first-line immunotherapy, despite the lack of concrete evidence of its efficacy in the expert consensus recommendations. There was a high level of agreement that first-line immunotherapy, which includes corticosteroids, typically methylprednisolone, that's an IV formulation, either intravenous immunoglobulin. A lot of times these modalities are used together at the same time so that we're not delaying treatment. And then oftentimes plasmapheresis can be initiated as well. Typically plasmapheresis will be kept off the table if it's thought that it might take down the steady state concentrations or therapeutic concentrations of the anti-seizure medications or delay us for initiating other immunotherapy, but it is often used as well. And then it is shown that early initiation of any immunotherapy is more likely beneficial than delaying the therapy. The biggest thing with starting immunotherapy is you want to make sure that you're ruling out infection. So then the patients are really falling into that cryptogenic NORSE at that point. And typically it can take 24 to 72 hours to really rule out that infection. So as soon as infection is ruled out, then we want to get first-line immunotherapy started. Escalation to second-line immunotherapy in patients who aren't responding to the first line is an important cornerstone in our treatment in general, and it is recommended that earlier aggressive treatment is generally associated with better outcomes. There's really not a lot of information, which the 2 talks have highlighted, to provide really specific timelines for escalation of therapy. But we have agreed on the earlier, the better approach. So the consensus statement recommendation is that escalation to second-line immunotherapy should be started within 7 days of seizure onset, provided that the first-line treatment was initiated without delays. And then the second line, I've listed some of the most commonly used examples there, and Dr. Muscal did highlight that first-line immunotherapy in patients with pathogenic antibodies that are identified or suspected should be treated with rituximab. But then there's clearly some differences in the providers who use other agents. In the literature, it was more commonly reported to use anakinra for the pediatric patients and tocilizumab for the adult patients. However, it should be noted that either option can be used for both adult and pediatric patients. And I briefly want to just jump in a little bit more about anakinra as you or your loved one may be on this medication. I'll also talk briefly about tocilizumab afterwards. I won't go into the mechanism of action because Dr. Muscal so nicely laid that out for us, but I want to highlight some important parts of the medication. It is administered typically IV in the hospital, so we're not having to poke you or your loved one if they already have IV access established. But in the outpatient setting, or as we're transitioning patients to be in a more home environment, then we may be switching to the subcutaneous administration. Again, highlighting that it can be used in both adult and pediatric patients. Dr. Muscal highlighted that it does have a very short half-life, somewhere between 4 to 6 hours. We typically, in the pediatric population where I have experience with it, give it as a twice daily injection. However, there is a lot of variability of dosing, and in adults, it may only be given daily. It is metabolized by proteases in the body. And so that what that means for you and your loved ones is there's not significant liver metabolism. So we don't have to worry about major drug-drug interactions, which is nice. And then it is excreted by the kidneys. So in severe renal impairment, we may need to make some dosage adjustments. The most common side effects that occur with anakinra are the injection site reactions. And those of you who are on or have been on therapy can likely attest to that. There's redness, itching, rash, and some pain. Bleeding and bruising can occur, but that is much more rare. We really, you all are probably the experts on this, but in the cases and in the reports in the literature, the injection site reactions are typically mild. They happen early during the treatment, lasting about the first 14 to 28 days. We also can see upper respiratory tract infections, as this is a medication that's suppressing the immune system or the ability to fight infections. And then some patients have said that there's headache, nausea, vomiting, diarrhea, some joint pain or overall malaise, like feeling like you have the flu, and then pain in your stomach. The contraindications are really any known hypersensitivity to the drug components, and anakinra is an E. coli derived protein. So if there's a known hypersensitivity to that, we caution patients and families, as you probably have been cautioned if you are on this medication or have a loved one on it, that there is a risk for hypersensitivity reaction. It's typically more pronounced in the first couple doses, but could happen throughout any duration of the time that it's given. And then there is a risk of infection as we are dampening the patient's ability to fight infections. So we don't want you or your loved one getting any live vaccinations while on therapy. There's also a risk of low white blood cell counts, as Dr. Muscal alluded to, and so those are more closely monitored for that first year on therapy. It is supplied as 100 milligram pre-filled injectable syringe. And those of you that have children that have been on this, you may have been required to expel some of the medication to achieve that prescribed dose. So when we're trying to hit doses that are lower than that 100 milligram. It is required to be refrigerated, but shouldn't be frozen, and it shouldn't be shaken as it can denature the protein. We want it to be stored in the original container and away from light, also to protect it from denaturing. And then really letting it warm to room temperature. And those of you that have been on it or have children on it can probably attest to that it can actually help reduce pain and when it's let warm to room temperature. And if it's left at room temperature for longer than 12 hours, then it will have to be discarded. There, I left a treatment guide that is really comprehensive in how to actually give the subcutaneous injection, although you are likely taught that at the time that your provider is prescribed that by one of the nurses, but just knowing that that reference is readily available. And then I briefly wanted to talk about some of the ways that we could possibly reduce pain with this subcutaneous injection for those of you that are on the injection currently or have children on it, because it is a challenge. This medication and shot is really painful, and it's because the medication is preserved with sodium citrate, and that's a form of citric acid, and that's making that medication have a lower pH and making it acidic, and that's what makes it more painful. And that's not uncommon for other biologic medications. Unfortunately, that can also be uncomfortable. So here are some tips to make that shot less painful for your child or for yourself. But since everybody reacts differently, your child may find that some of these tips work well and that some of these are ineffective and actually don't make the shot feel better and actually make it more painful. But we definitely don't want to skip out on letting that syringe warm to room temperature prior to injection, as universally it is more painful when it is cold. And then trying to make the injection part of the daily routine and really involving your child in the decisions on where in the house they want to get the injection done or where they want the injection site of administration to be that day can be helpful. Let's see, distraction tools for you or your child can be super beneficial for patients. There's something called a shot blocker, and it is an inexpensive, tiny plastic device, and it can be exceptional for some patients. You can see it in yellow in the picture on the screen. On one side, it has tiny nubs that are really uncomfortable. They're not painful, but when pressed to the skin, it's going to confuse the brain for a few seconds and act as a form of distraction. So the brain is focusing on those annoying nubs and then not going to pay attention to the injection as much. It works well for a lot of kids, and it's pretty cheap to buy, as I mentioned. And then there's a Buzzy Bee. It's another distraction tool that vibrates, and you would place it above the injection site as you're giving the injection. And it's working like the shot blocker to really distract the brain. You can use both of those together. You just may need some extra hands. And then trying to suck on candy or watching a video, chewing gum, blowing bubbles can also be some good distraction techniques. Aiming for fatty areas, as this is a subcutaneous injection. So going for those areas with the most fat, and I've depicted on the right-hand side, the areas that's recommended for the pediatric population. Some say the belly is the best, while others prefer the back of the arm. So really finding out what is best for your child. Some patients say icing the injection before makes those injections, helps to alleviate the pain. However, I've had some patients say that actually warming up the injection site before helps. And then the other thing that we've had some caregivers do is they actually have changed the needle size. And so, this comes in a pre-filled syringe. So they have been taught by the pharmacist or the nurse or the provider how to change the medication over into a smaller injection that's maybe used for insulin. So the TB or insulin syringes, and that can help really reduce the pain. You would have to properly calculate the dose if you're using an insulin syringe, as those are marked in units versus ml. So there can be some trickiness with administration, but it definitely can be done. And then some patients, if they apply the hydrocortisone or antihistamine creams to the injection site, can reduce those risks of those injection site reactions.
Dr. Calvert, I just wanted to let you know from a time standpoint as well,
Okay.
just a couple more minutes that we can get to let people ask some other questions for the panel discussion.
Sounds great. And then there are indwelling catheters that we've had a patient that was getting multiple administrations during the day. These are not without pain themselves, as they're placed like an IV and have to be replaced every day and have a risk of infections, something you could talk to your provider about if insurance covered that. And I will briefly run through tocilizumab. It has a longer, more variable half-life. It both exhibits linear and nonlinear pharmacokinetics, so there are changes in half-life. So you can see that the infusions can be given weekly to monthly, and there's some variability in the subcutaneous infusions, but typically we see IV outpatient infusions for these patients. It doesn't cross the blood-brain barrier, but we think that with prolonged status that blood-brain barrier is disrupted. And as Dr. Muscal mentioned, the peripheral changes are affected as well. So it's probably working to help decrease all of that immune response. And then there could be potential for medication interactions. It has a lot of similar adverse drug reactions, but one I'll call out is the rare or serious GI tract perforation, and it's typically seen after 6 months of use. It can increase blood pressure and liver enzymes as well as cholesterol, so it has a few more things to monitor. And then it is similar in that is kept refrigerated and when it's given subcutaneously. Then in the ketogenic diet, it's really considered from the recommendations to initiate that early. As Dr. Muscal mentioned, we think that not only does it have anti-seizure, but anti-inflammatory activities and possibly neuroprotective effects. And there are different acute adverse drug reaction or adverse reactions with the ketogenic diet, as well as more chronic complications. So they're listed the acute. And then cannabidiol, the consensus recommendations really showed that there was insufficient data to recommend that in the acute phase. There was a small case series that demonstrated some effect for patients with fires. There's a potential that it has anti-inflammatory effects in addition to the anti-seizure effects, which is why it could be a promising medication, but it shouldn't take the place or delay that immunotherapy or the ketogenic diet initiation. So Dr. Muscal showed you this depiction from the consensus recommendations, and it was really just highlighting to initiate that first-line immunotherapy early in that first 72 hours of seizure onset or earlier if you've ruled out infection. And then considering the ketogenic diet really in all pediatric patients and then in adults if possible in that first week, and escalating to second-line immunotherapy within 7 days if there's no response to first line. In the post-acute and chronic phases, there's really a lack of literature to say what anti-seizure medication is going to be helpful, but we know that most of the patients and your loved ones are characterized by drug-resistant epilepsy. And I've listed some of those there, and we can talk more in the breakout group about some of that information. And then the ketogenic diet in the post-acute and chronic phase has seen to be beneficial if it was beneficial in the acute phase as well. Then the immunotherapy, I think Dr. Muscal did a nice job showing that there is utility in the post-acute and chronic phase likely, and there's probably more that we need to learn about that. And then Dr. Risen did a really nice job showing us that the majority of patients present with long-term neurologic sequelae, such as cognitive impairment and functional disability, and that we don't have a lot of literature to help us understand that. But that there are some important considerations, which I will go into more detail in our breakout group about how we think about these patients and how we can extrapolate information from acquired or traumatic brain injury literature. And so I'll just flip through these, which we can talk about. And to summarize, there's really just a lack of data about the pharmacologic management, but the international consensus recommendations give us a good guide for families to advocate and clinicians to really understand. And we know that, or we're learning that early initiation and aggressive escalation of immunotherapy may improve long-term outcomes. Again, if you're able to put any data into the NORSE family registry, that really is going to be what helps us understand the disease entity for you or your loved one.
Wonderful. Thank you. Gosh, we've heard so much great information and some overlap, which I think really highlights some key questions that people have had. We'll hop we'll start the panel discussion next. Andrew, you probably stop sharing your screen. I think it may make it easier for me to be able to see people. I have a few, if people want to type questions into the Q&A, we have about 5 minutes for the breakouts or the panel discussion. We can probably extend that by a couple of minutes into our break if people have a lot of questions. Some of the questions have already been, addressed by our different talks, but please feel free to put things in the Q&A, and I have some other ones that people sent in beforehand. So one of the questions I think that several people had mentioned, and I think Dr. Calvert just highlighted at the end a little bit, but was about the use of immunotherapy in the chronic phase. And I just wanted to make sure that any of our panel didn't have anything else they wanted to add about that. If immunotherapy should be used in the chronic phase, or what we know about that.
You want me to?
Yeah, why don't you answer that?
Yeah, I know that it's disconcerting to always hear that we don't know. And I think early on in my training, I had one attending that had said that as rheumatologists, not knowing doesn't mean that we can't ask the question or still think about doing. I think the issue since 2019, when the Italian group shared one case, and then a couple years after, the group shared 5 of their patients, I think it ends up being a shared decision making, educating oneself about the medications, whether you had them with the initial event, or if the initial event was years ago. We probably were not aware that we could repurpose some of these medications, though I think we're still learning how effective they are in not just reducing inflammation, but actually reducing seizures. And I think you just have a frank, honest discussion, and hopefully you have physicians that understand that you have become the expert, right? You have a PhD in your child's condition more than anybody else, and have a discussion on, do we have any proof the immune system is activated? As I put in the chat from one of the parents, is that by chasing down some of these labs from blood work? Is it important enough to do a lumbar puncture to answer those questions? Do you have a sense that every time your child or adult loved one has an infection, it re-triggers seizure burden, not just when they have fever, as we all know that fevers can reduce the seizure threshold. And you sort of take some of those observations as the expert of your child or loved one, and have a real risk-benefit conversation with your medical team, knowing that you can make infections more prominent or worse, and depending on the quality of life and the seizure burden, and whether bringing other standard of care interventions to reduce seizures allow you to dampen things, versus thinking about a medication like anakinra, which unfortunately in the outpatient setting can only be a shot. And as people have put in the chat, younger and older kids really dislike that shot. And I think Dr. Calvert really spoke well about some of the tricks of the trade, but some kids are too smart for those tricks of the trade. And I can circle back around after my answer, whether there are any other ways to get at that one inflammatory pathway that are potentially less problematic. So I think it ends up, until we get more information from families and other researchers, it becomes that sort of back and forth discussion, like a game of tennis.
Thank you for giving your thoughts and response on that. I just wanted to make sure to ask that one clearly, because there were several questions about that. The next question would be for Dr. Reisens. We had a few people comment on mood and behavior concerns, a pre-submitted comment also about the effects of long-term epilepsy on depression. So I was wondering, I know that's the part of your talk you didn't fully get to, but was hoping you could help share your thoughts on those parts of outcome as well.
Yeah, so mood and behavior problems are really incredibly common following acquired brain injuries. I don't think that makes it easier, but I guess it is important to know that this is something we're familiar with and not out of character, unexpected. I think the importance is kind of acknowledging the symptoms and then addressing it through kind of the standard behavioral therapies that are available, as well as medication management, depending on the severity. but I think it's just recognizing it is probably one of the most common side effects following brain injury. And that's why I think there were so many questions on it. So I don't know if there was something specific.
No, I think that covers it. If someone has something else they wanted specifically for Dr. Eisen to cover, please put it in the Q&A or raise your hand and we can make sure to address that. The next kind of group of questions that we had a lot of interest in, which I think may come up in the breakout session as well, but was about any data for medications in the post-acute phase. So I'll have this for Dr. Calvert. And you know, she touched about that briefly on her slides, but we had several questions still kind of asking about if there's any data to help guide that treatments.
I'd be happy to address that. Unfortunately, there, you know, like many of us have answered and that we heard, you know, we'd have some dissatisfying answers. We don't have an anti-seizure medication or medications that we know this is the blockbuster medication that will help you or your child. It is much like, you know, we talked about the complications with refractory epilepsy in the majority of patients, and majority of you or your children probably are on multiple anti-seizure meds and require that polytherapy. We take the approach like we would take the approach to treat refractory epilepsy. And unfortunately there, we don't have a crystal ball. We can look at what are your seizure types. And we know that there are specific medications that may be more beneficial in certain seizure types. And then there's unfortunately a lot of trial and error, which is not fun for you or your child to see what medication, what dose is the most efficacious. And then there's some thought to those medications that some people have brought up in the chat, such as Epidiolex or the ketogenic diet as a medication therapy that could also have some anti-inflammatory and anti-seizure effects. So those are becoming important to study more in that chronic phase.
Thank you. I'm going to do one more question and then we'll let everyone have a slightly shorter break, a 5-minute break before we come back to hear some research updates from the family registry. But there was a couple of questions. So Dr. Eisen, this is for you. I know you're also typing an answer, it looks like right now too. But a couple of questions about cognitive recovery that I'm going to kind of group together for you. So one person had asked, what can we do, if anything, to slow the progression of brain atrophy? There was also a question about cognitive recovery as our focus right now. What has worked? Are there experts we should consult? Someone was wondering about kind of activities that could be done to help stimulate the brain that would in the long run assist in improving recovery. And so I know those are 3 separate questions, but was hoping you could maybe give some insight into the cognitive recovery.
Yes, so for just from a brain atrophy and imaging perspective, I kind of always say you're not your brain MRI, right? So I focus more on the function. And I think getting into kind of atrophy in the chronic course really is, you know, in Dr. Muscal's area, and really what is kind of the ongoing pathology. And I think a lot of research is being done to that, if there isn't, besides ongoing seizures. So, but from the cognitive perspective, I think one comment or in the Q&A was about the slide that showed the 3 patients or children with FIRES who had, you know, cognitive decline. And I'm not at all saying that this is a degenerative process because it's only 5 patients. And, you know, we're limited by that last point in time. I don't know, you know, in another 6 months or a year, what would that increase, plateau, continue? I'm not sure where that trajectory is going. And it's such a small number. What it does is say, hey, we have a lot more to learn, and really following the neurocognitive and behavioral profiles over time and in the long run is really important. So I don't think it's saying it's a degenerative course. I think it's saying, hey, we've got a lot to learn. And this isn't necessarily just the same as a traumatic brain injury. You can apply a lot from what we've learned from other types of brain injuries to management. And we can, you know, kind of as we're trying to figure it out. But ultimately, we need to know the course specifically for NORSE and FIRES, if that makes sense. So, and then as far as things you can do, depending on you or your loved one's level of function, there are varying levels of cognitive rehabilitation. So for higher functioning, if just working on kind of memory processing, organization of thoughts and speech, you can work with a cognitive rehabilitation therapist. And those are typically speech language pathologists. Some neuropsychologists and psychologists also do this work. And it requires a lot of training and learning skills and learning, additional compensatory techniques. And sometimes generic brain injury experts might have more of these resources. So if you were just to look under NORSE and FIRES, you might not find anything to look under brain injury experts and cognition. You might be able to find more information, if that makes any sense, or traumatic brain injury, getting even more specific. Just because it's so common, there are a lot of therapies being used in those other conditions, which can still be applied to NORSE and FIRES.
I think that's helpful. I know some of what we've heard is there can be challenges with access to resources. And I think knowing, what to look for outside of just the terms NORSE and FIRES can be helpful. I will also add that for people with that figure with the IQ scores too, I think the other thing to point out is that some patients showed improvement in their IQ over time as well. Again, very small, 5 patients, 3 that had a decline during that period. But I agree. I don't think we should take away from that there is a kind of ongoing, that we have, data that there's an ongoing degenerative process. All right. So I think with the idea that everyone might need a couple of minutes to stand up and stretch and do a bathroom break. I know we have lots of unanswered questions that our panelists and some of the rest of us will try to get through in the chat and in the Q&A. So keep an eye on those and we'll message those, but we'll take a brief 5-minute break. And then come back to hear about the family registry. I am going to put a slide up during the break with some opportunities for people if they want to get involved more about any of the research opportunities we've discussed or with the Norse Institute as well. So you can take a moment to write down how to get in touch with those people or get involved with some additional opportunities as well. And then we'll see everyone back at, sorry, I'm just in a different time zones. I want to make sure I say it right, but ideally within 5 minutes, so at 11:33. All right, thank you, everyone. All right. So I know that was a short break, but I wanted to make sure that we kind of keep moving through. I think there's lots of great questions and discussions that have come up already. And we have another talk on an update with the research that I'll introduce in a minute. And then we'll have some breakout sessions to go into more detail about some of the questions people have asked. But next let me just switch over to where I am. So next, we are going to hear from Karnig Kazazian. He is a PhD candidate at Western University working with Dr. Tennille Gofton. Many of you have contributed information to the NORSE family registry already. And so we'd like to take this opportunity to really share with you what information we are learning from this data. And then there will also be contact information for those of you who haven't participated if you are interested in participating. So we're able to see your slides. So Karnig, you can start whenever.
Wonderful. Thank you so much. Hi, everyone. So like Dr. Eschbach said, today I'll be talking about the NORSE and FIRES family registry. And for those of you who are not aware about the registry, it's an international online registry that invites people who have been affected by NORSE or FIRES to contribute demographic, clinical, and long-term outcome information pertaining to their illness. The registry is certainly a collaborative effort led by Dr. Tennille Gofton, along with several members of the NORSE Institute. And today I'll be talking about how you can participate in the registry, the types of questions you can expect to be asked, as well as some preliminary results that we have gathered from over the years. So as I mentioned, the registry really is designed to gather information about people affected by NORSE and FIRES worldwide, with ultimately the goal to use this information to deepen our understanding of NORSE and FIRES, to improve care for people affected, and also to use this information to better inform future research questions and research studies. And quite importantly, the registry certainly provides an avenue to families, survivors, loved ones, and caretakers to directly contribute to ongoing research that aims to better understand NORSE and FIRES. So some of the types of research questions we've been asking is, what is the worldwide distribution of NORSE and FIRES? What are both the short and the long-term outcomes? What does the trajectory of recovery look like? And are there certain risk factors that predispose people to NORSE and FIRES? So how does it work? The survey is administered through REDCap, which is an online secure clinical survey platform that's used by several research institutions around the world. The survey is open to both survivors and non-survivors of NORSE and FIRES. So by that, we invite current survivors to enter data into the registry with either the help of surrogates, their loved ones, or themselves. Loved ones or surrogates can also enter information based off on their loved one's behalf. And also, I really would like to emphasize that we also welcome information of people who have passed away from this illness. We invite loved ones and surrogate decision makers to enter data that they have for their deceased loved ones. And we also invite clinicians to enter survey information into the survey on behalf of their patients. So some key survey features: the consent is done electronically through REDCap. The survey is currently available in English, Spanish, French, Mandarin, Hindi, and Portuguese. So we really are trying to make it as accessible as possible to a worldwide demographic. There are save and return options built in within the survey. So if you don't have a specific answer to a question on hand, you can save and submit what you have, and a link and passcode will be generated for you, and you can return back and enter any missing information. And we also have follow-up surveys from the point of illness onset at 6, 12, and 24 months after the fact. And this is administered through email notifications. For people who've been affected by NORSE and FIRES for greater than 2 years and are alive, we present a current outcome measures survey for you to fill out that's representative of that point in time. And the survey will be open until 2025. Typically, it takes about an hour to complete, but on our landing page on the NORSE Institute webpage, we have a abbreviated PDF that describes the types of questions that we ask, and this way you can prepare those to gather the information that we would be asking in the survey. And if you don't have an answer, you can always click the I don't know option for every question. So the types of information that we collect include demographic information, information pertaining to past medical history, information pertaining to hospitalization and discharge, the presentation of illness, and then different types of diagnostic evaluations, communication between healthcare teams and families, and for survivors, long-term outcomes, survivorship, and quality of life. As of the middle of May, we have 98 participants enrolled in the study from across the world. As you can see, the most prevalent are those participating in the English survey, but we also have people utilizing our international languages, French, Spanish, Mandarin, and Portuguese. Amongst all of our participants, we have an even distribution of male and female participants. And we also see that a majority of participants are pediatric, and both in adult and pediatric, a majority are survivors. We have a very decent worldwide distribution. While half of the participants, or just over half, come from the United States, we also see representation from South America, Africa, Asia, Australia, and Europe. So this shows the international distribution of the survey. Of the participants to date, 71% had a preceding fever and were categorized as NORSE, whereas just under 30% were NORSE without preceding fever. You can see that a vast majority of participants are pediatric participants, and we also do have a significant number of early adults that were diagnosed with NORSE or FIRES in this specific population, or in this specific data set, sorry. Our survivorship is 70%, so 69 of the 98 participants in the registry are survivors of NORSE and FIRES. And at greater than 6 months after onset, we see that the mean number of anti-seizure medications that participants are on is 4. The mean number of seizures per month in this data set are greater than 10 per month, and almost all except 3 survivors have developed drug-resistant epilepsy. And in respect to quality of life, we ask participants, caregivers to rate quality of life and cognitive outcomes, 0 being worst, 10 being the best. And what we can see is that both self-reported quality of life and cognitive outcomes are rated low. There are no statistical differences across all participants for quality of life, but we do see that statistically pediatric cognitive outcomes are reported to be worse than adult cognitive outcomes. And just a couple final notes. Our goals really are to continue promoting registry participation. We really do thank everyone that's participated so far. We're always looking for ways to increase the accessibility and identify ways to improve the registry. So we're always welcoming feedback. Our emails will be shown on the next slide, and also you can find it within the registry landing page. And we'll continue to examine associations in the data. And we've just started doing a deep into the data set that we have. And as a reminder, the registry will still remain open for a couple more years. So the easiest way to access the registry is to go to the NORSE Institute webpage, and there's an entire tab on the top right corner, our NORSE Family Registry. You can take a screen capture of this slide or take a second to write this down. You can email myself or Dr. Goffin if you need any assistance or have any questions. And you can also take a picture or scan this QR code, and it'll take you directly to the registry website as well. And on a final note, I just want to acknowledge that, participating can take up time, and it could bring up memories that you may wish you could forget, but your information is really helping us move this research forward. And we really deeply appreciate all of the time and the commitment that people have contributed towards this registry. And we would also like to acknowledge that this registry is generously supported by the Robert and Co. NORSE Registry, our NORSE Family Registry Memorial Research Fund. So with that, thank you. And if you have any questions, please feel free to reach out directly, and I can also answer some in the chat afterwards as well. So thanks.
Thank you, Karnig, for that. There is a couple of questions in the chat that I'll just have you take a look at and respond to people about the registry. And then next, we're going to move on to our breakout sessions. One thing I did want to mention first is that if anyone has a phone number in as their name in Zoom instead of their name, if they can go ahead, you can go to the right corner of your screen where there's the little dots, and then go to rename. And if you can rename yourself with your name, that'll help for the conference and also for the breakout sessions as we're interacting and talking in smaller groups. So for the final part of the conference, we will now move into smaller breakout sessions. This will be an opportunity for additional conversation regarding the morning's topics and an opportunity to connect with other patients and families and clinicians. In addition to our speakers from this morning, we have 3 additional moderators that I would like to introduce. So the first is Dr. Lawrence Hirsch. He's a professor of neurology and chief of the Division of Epilepsy and EEG at Yale. He's the co-director of the Critical Care EEG Program and Fellowship, and also co-director of the Comprehensive Epilepsy Center at Yale. He's the principal investigator of the NORSE FIRES Open Biorepository and co-chair of the NORSE Institute Medical Science Advisory Board. He will facilitate the breakout session discussion with investigators getting involved in research. So some of you will get a chance to talk with him more in the next groups. Our next moderator is Dr. Lauren Treat. She's a pediatric neurologist and palliative medicine physician at Children's Hospital, Colorado. She will facilitate the Connect families with children who are living with NORSE or survivors of NORSE. And so some of you will get to meet her more. And then Dr. Marissa Kellogg is an adult epileptologist at Oregon Health Sciences Center and is the director of the VA Portland Epilepsy Center of Excellence. She is going to be moderating the Connect Families with Adult Survivors of NORSE session with Dr. Maggie Gopal. Nora, you guys have all met at the beginning of the conference. She is also going to be moderating one of the breakout sessions, and then Dr. Calvert and Dr. Risen as well. We will have our breakout sessions will go until 12:20 p.m. So it ends up being a little bit less than the 40 minutes. So moderators, you can just make sure to keep a track of the time and come back to the group at 12:20. That would be great. When we come back to the group, we're going to ask each moderator to provide a key takeaway from their group's discussion that may be relevant for the entire group. If there is a key takeaway, again, doesn't need to be a whole overview of the discussion, but just if there's kind of a key takeaway that you want to bring back to the whole group, we'll have a few minutes to go through that before our final wrap up. I believe you all should, when Maggie sends us all, that we'll all end up in our groups, but we will be troubleshooting if anyone ends up in not in a group, or one of the groups that we had was the rheumatology group, which is no longer able to occur. So we'll make sure everyone ends up in a group, but reach out to us if there's any trouble. Filtering back in, but we'll have you start, with key takeaways, a key takeaway from your group.
Well, I think it's a little challenging to condense it into one key takeaway, but I think, our survivors and caregivers and family of survivors, of course, expressed frustration about ongoing seizures and, the balance between trying to find better treatment for their seizures and quality of life and not rocking the boat. So I think with the limited knowledge we have of NORSE these days, there are lots of different treatment options, but none of them are perfect. And trying to find that balance between side effects and stopping the seizures is challenging. And we just talked briefly about all the different treatment option possibilities, including medications, surgical treatments, diet, and mental health treatment also being very important.
Thank you for sharing. It sounds like you guys covered a lot, and I'm sure could have spent more time discussing all those things as well. The next group we're going to go to is a similar group with Dr. Treat, so looking at connecting families with children living with NORSE and FIRES.
Thanks, Dr. Eschbach. We had a we had a really great connection time as well, and I think one of our main takeaways was the power of kind of reducing the isolation that families feel. This is a rare disease, and it's a very sudden and shocking thing that happens to families. There's a lot of trauma associated, a lot of emotions associated with it, and having compassion for one another, and even just reducing that isolation that you can feel as a family trying to support a child, especially trying to be the parent, trying to know what's best for them, how to plan for them, how to advocate for them. We talked a lot about that empowerment that can come from knowing what other people have found helpful, and knowing that they have resources in one another as they try their best to plan and advocate for their children. It was really a nice time to be together. Thanks.
And thank you for summarizing what sounds like a lot of additional things that were covered, but summarizing those key takeaways from your group. The next group that I was hoping we could hear from is Nora with your group on connecting after bereavement.
So it was a very small group. And some people did email me to say that it was either they're working or it was just too hard to come. And especially since this conference was focused on surviving NORSE, and if their child or loved one died, it would be very hard to sit through. But the people who were there what was raised is that NORSE in general is a traumatic experience. It's traumatic and it's experienced in isolation. So our plan is the NORSE group will host 2 other Zoom calls. We'll try to organize this to really address PTSD. It's been brought up in the chat, and so we have to think about what we can do and to get some kind of Zoom call or workshop on. And we were thinking that it would be 2 groups, one purely for those who lost someone, and then those who feel utterly bereaved, whether the person survived or died. Thank you.
Thank you, Nora, for sharing those. It sounds like you guys covered a lot as well, and then also developed a plan to continue to support and connect with each other moving forward, which is important. The next group, kind of feeding off of that a little bit, I thought it might be nice to hear from Dr. Risen and her group as well.
We had a really wonderful group and a lot of sharing of experiences and stories. And interestingly, from someone who's actually actively in the ICU, a family member of someone in the ICU, all the way through to survivors. We talked a lot in our group about, I think, similar themes from what you're all hearing, the challenges and the difficulty in really predicting the outcomes, as well as how the treatments themselves contribute to function and quality of life overall, and what to do. But it was really a lot of sharing of really profound experiences that everyone is going through. Really is a traumatic event. So I'm so excited to hear about these programs that y'all are working on. I think they'll be really important and impactful.
Thank you for sharing. And then the next group would be Dr. Calvert, related to anti-seizure medications. I know there's probably a lot you covered as well, but if there's any kind of key takeaways that you want to share with the group.
Yes, thank you. I think we also had a great group and some robust discussion. There were a lot more pointed questions. So again, it's hard to kind of pick out a theme, but I would say similar to the first Family Connect group, we really talked a lot about the challenges between what is brain injury versus what is medication side effect. And so that was a common theme that was strung throughout. There were specific questions to medications that maybe are particularly helpful for this patient population, but could also be contributing to cognitive decline. And so kind of the balance between seizures and side effects would probably be one of the bigger themes. But we had some great interaction from some of the experts in Houston, so it was great to have their expertise there as well.
You had a pretty large group, so I'm glad it sounds like a few of you were able to provide input and help moderate. And then lastly, with Dr. Hirsch finishing up with a discussion with investigators and ways to get involved with research, which may provide some answers to some of the unanswered questions that have come up in the other groups as well.
Yeah, so we actually had an all professional group. And the researchers were listening, so we actually realized how important the chronic phase is to everybody. And we talked about ways we could pivot some of the inflammation research to the chronic phase and pay more attention to that. And I did want to make one point to patients and families. If people know that you have samples, including pre-existing ones, whether it's brain tissue, which is very hard to come by, but very useful, or acute blood and spinal fluid samples that were frozen and stored. We can still use those in the biorepository. So let us know if you have those. You can just email norse@yale.edu and we can let you know if we can use those. So that's a good way to get involved. And don't forget about the family registry, of course. That's it.
And those contact information is on that slide that I shared during the break as well. So thank you, moderators, for sharing key takeaways from the group, and to all of our speakers for their time and participation in the conference this year. Just to finish up, I just want to say a few things. So each year, the conference is based on patient and family input and feedback. So please write down your ideas and enter them on the evaluation form that you will see that I'll plan to email out to each of you in the coming weeks. I was also going to share the slide of NORSE opportunities one more time for everyone to see as well. So if you guys can see that as well for those that are interested. And then I really hope that this conference was informative for everyone and provided an opportunity to connect with other families as well as physicians and researchers so we can work together to improve the lives of people impacted by NORSE. Please also don't forget about the Medical Scientific Symposium, which is targeted a little bit more at clinicians and researchers, that is scheduled for tomorrow at the same time. This will include a different list of speakers and additional updates on NORSE research. And so thank you all for attending, and please keep in mind any feedback to help improve the conference next year to continue to help meet the needs of our patients and families. Thank you.